A very good afternoon to all, and today I am Dr. Ritisha Bhatt, Assistant Professor in the Department of Respiratory Medicine, and we will be talking about use of BIPAP and high flow nasal cannula. So this is a BIPAP machine, typically how it looks. BIPAP stands for bi-level positive airway pressure. So why bi-level? Because in this we can set two pressures. One is the IPAP, that is the inspiratory positive airway pressure, and second is the EPAP, that is expiratory positive airway pressure. Hence it is called as BIPAP. This is how a typical BIPAP machine looks, and here is the interface, which is a mask by which we hook on our patients to the BIPAP machine. So when do we start a BIPAP? So typical indications for BIPAP are when the pH is below 7.35 and the PCO2 that we assess on ABG is more than 45 mm of mercury, and the respiratory rate of the patient is more than 20 to 24 breaths per minute despite of standard medical therapy. It remains the preferred choice for patients with COPD who develop acute respiratory acidosis during hospital admission. However, the clear-cut indication of NIV in hypoxic respiratory failure, where only the oxygen is low and carbon dioxide is normal, is not very established. But we've been using BIPAP in our COVID-19 patients. So why we are using NIV? Because there was a study which said that de novo acute respiratory failure, which includes as a preventive strategy for avoiding intubation, we are using the BIPAP therapy. In one pilot study, they used BIPAP in patients who had early ARDS, which was defined as a PF ratio between 200 to 300, and they showed that there was avoidance of intubation in this patient by the use of BIPAP, and it reduced the cytokine levels as a favorable outcome. Hence, we've been using BIPAP in our COVID-19 patients also. So, sorry? Excuse me. Slides moving. So what are our contraindications? Are the slides moving now? No. So we've talked about the indications of BIPAP. Now we are coming to contraindications. So which are the patients in which we don't have to use BIPAP? The first and foremost are the patients in whom there is inability to protect the airways. By this, we mean that patients who are comatose or who have cerebrovascular accident or who are confused and agitated. In these patients, they will not cooperate with the BIPAP interface, so we should not use BIPAP in these patients. Patients who are hemodynamically unstable. Those are patients who have arrhythmia or who have hypotension and are on very high dose of inotropes and vasopressors. The third is inability to fix the interface. If the patient has any facial trauma, facial abnormalities, and anything that we cannot use the mask on the patient, in these patients we should not try BIPAP support. Other is severe GI symptoms. Severe GI symptoms like severe vomiting, obstructive bowel, and severe hematemesis. In these patients, NIV should not be used because if the patient is vomiting, then he won't be able to use the mask properly. In patients of massive hemoptysis, we should not use BIPAP. Patients who are having copious secretions, we should not use BIPAP. And in patients who are post-cardiac arrest and we have revived after CPR, in these patients, we should not use BIPAP and we should go for invasive mechanical ventilation in these category of patients. So, what are the predictors of BIPAP failure? So, when we are using a BIPAP in a patient, the patients who have high severity or score of illness, Apache 2 and SOFA high scores, these are patients where there will be BIPAP failure. Older age group patients, failure to improve after 1 hour of BIPAP therapy, multi-organ involvement. In pre-morbid status, they have inability to perform self-care. Patients on whose ABG, the mean pH is less than 7.25 and the mean PSCO2 is more than 75 mmHg after 2 hours of giving BIPAP therapy, and patients who are difficult to identify the etiology of acute respiratory failure, or those who have ARDS and pneumonia and the PF ratio is less than 150, or patients who have high tidal volume generation. All these are patients who are prone to have NIV failure. Hence, these patients should be very critically monitored by the critical care team, and we should decide when to intubate these patients. So what is the interface? When we are using a BiPAP machine, we can use different interfaces. We have different, like a full face mask, we have helmet mask also, we have nasal pillows also. In the COVID pandemic, we are using a full face mask. Some centers which have available, they are using helmet masks also. So the interface can be a full face mask. Next is, what are the settings? The settings should be that when we are starting, as I told you, it is a bi-level because we have two pressures, the inspiratory pressure and the expiratory pressure. So once we are starting the machine, the inspiratory pressure that we can keep, we can start from 10 mm of Hg and we can escalate the pressure. The expiratory pressure we can start from 5. Once the patient is accustomed to the interface, in 5 to 10 minutes we can increase these pressures. So what are the target? In normal patients, the expiratory positive airway pressure should not go above 8 cm of water, and the IPAP should not go above 20 unless it has been prescribed by a specialist. So these are the settings that we need to keep our patient on. The mode should be ST mode. ST stands for spontaneous and timed. It means that whenever the patient will breathe, the BiPAP machine will help in that breath also. And if the patient is not breathing, then at regular timed interval, it will also give the breath to the patient. So mode has to be ST. The EPAP pressure has to start at 5. The maximum can be 8. The IPAP pressure you start at 10. You can increase it. It can be maximum up to 20. The backup rate that we keep is 16 to 20. That means if the patient is not triggering his breath, at least 16 to 20 breaths the machine would be giving to the patient. Now we come to IE ratio, which stands for the inspiratory is to expiratory ratio. In COPD patients, our aim is to increase the expiration phase. Hence, in that we keep the IE ratio to 1:2 to 1:3. Next is the inspiratory time. By default, in COPD patients and respiratory patients, we can keep it to 0.8 to 1.2 seconds. After initiating BiPAP, we need to get an ABG, and that ABG has to be taken within 1 hour of initiating BiPAP. If the patient is not improving, if the carbon dioxide is not reducing and the respiratory rate is not reducing and the oxygen, we are not reaching a target oxygen of 92%, then we should consider the patient for invasive mechanical ventilation. A very important point here is that some category of patients who have COPD, in those patients, our target oxygen should not be 95 or 96. The target here should be 88 to 92%. So in these patients, we are not going to target 100% oxygen. We have to target 88 to 92%. Next, we will be discussing high flow nasal cannula. Next presentation. Yeah. Next, we are going to talk about high flow nasal cannula. So this is how a high flow nasal cannula looks like. We have a specialized nasal cannula which has heated inspiratory circuit, and it is connected to an active humidifier. This is an HFNC machine. I am happy to announce that we have one HFNC machine in a respiratory ICU already. And here we have the air oxygen blender, and here is a flow meter. So when people ask me that we have oxygen mask, we have high flow mask, why do we need an HFNC? It's a pricey machine. Why do we need to procure it? So when we are talking about conventional oxygen devices, they provide lesser flows than inspiratory flow rates. Lesser flow means we can only give oxygen up to 15 liters per minute. The higher flow rates when we are giving to patients, one is the flow meter is only up to 15 liters, and we give it to the patient, there is less conduction and pulmonary compliance is less because that air is dry and it is cold. Then we are not able to maintain the FiO2 ratio in these machines with precision. And the mask and reservoirs that we are using as interface, they act as dead space. Hence the ventilation comes down. So these are the needs why we need a high flow oxygen cannula. So these are the benefits of it. One is high flow washes out the carbon dioxide in anatomical dead spaces. It creates a positive nasopharyngeal pressure. and the FiO2 remains relatively constant. Why? Because we can fix the FiO2 in this machine. The gas is generally warmed at 37 degrees Celsius. So the patient in whom we are applying an HFNC, they will not complain that we are having a cold buff of air against our face. And it is completely humidified. So he will not complain of dry mouth and dry airways. And it will help to keep a good mucociliary function, and there will be less discomfort to the patient as compared to the other high flow devices. So the key benefits are that because of the optimal humidity, there will be a good mucociliary clearance, there will be comfort to the patient, and the flow. First of all, we can give high flows to the patient, we can give up to 60 liters per minute, and there would be accurate oxygen delivery to the patient because we can control both the flow and the FiO2, and there would be washout of anatomical dead spaces, and this machine also provides a low level of PEEP. It means that for every 10 liters of flow that we are increasing, we give 1 centimeter of PEEP to the patient. PEEP stands for positive end expiratory pressure. So the alveoli of the patients will not collapse. They will have some pressure which will aid in respiration. So what are the clinical uses? Where currently are we using HFNC? It is used in acute respiratory failure, which is mostly hypoxic. In hypercapnic respiratory failure, we generally should not use HFNC machine, and we should take the opinion of a respiratory specialist for that. In immunocompromised patients, we are using these machines. Patients who have given a do not intubate or resuscitate consent, we can use this machine. Pre-intubation, for giving patient 100% oxygen, we can use this machine. After extubating the patient who have high oxygen requirement, there again we can use an HFNC, and in acute heart failure, we can also use these machines. So there are the difference between HFNC and NIV. As we had already talked that non-invasive ventilation is with us. So why do we want to have HFNC? The first and foremost is that with NIV, we can fix the pressure, but the flow is variable. With HFNC, we can fix the flow also, the pressure is variable. With NIV, we are using a mask, so it has a dead space. But this anatomical dead space is alleviated by an HFNC. The tidal volume increases with the NIV, but there is no effect on tidal volume with HFNC. The comfort is definitely more with HFNC because with NIV we are using a mask and we are tightly strapping it to the patient's face. So most of the time he feels suffocated and he is not able to cooperate with the machine, and hence is not able to breathe properly. So that comfort level is very much increased with HFNC. And the feedback of the patient is available with NIV, but with this we don't have a feedback because he doesn't know. We'll have to monitor how much is his oxygen going, how much is the respiratory rate. And we have to titrate it arbitrarily for HFNC because we'll have to monitor the parameters and titrate it. However, for NIV we can look at the tidal volume and we can objectively titrate that machine. So where do the Indian guidelines stand on the use of HFNC and NIV in COVID-19 patients? So the Indian COVID guidelines say that HFNC definitely reduces the need of intubation. So about NIV and HFNC, initially in the pandemic, everybody had concerns. Then since COVID-19 is an aerosol generating, is spread by aerosols. So if we use HFNC and NIV, are we generating more aerosols? So they say that is not a concern. Studies have been conducted out and these can be safely used. So what should be the setting of an HFNC? It should be started at a flow rate of 20 to 30 liters per minute and the FiO2 should be 40%. And then we can titrate it upwards as per the SpO2. The NIV settings we've already discussed that it should start at inspiratory pressure of 10 and expiratory pressure of 5. So now we come to mechanical ventilation. So we see that COVID-19 is causing severe ARDS in patients. So how do we define ARDS? It is defined as an acute disorder which starts within 7 days of inciting event. It is characterized by bilateral lung infiltrates and severe progressive hypoxemia in the absence of any evidence of cardiogenic pulmonary edema. Here we see the PF ratio of the patient. PF is PaO2 and FiO2 ratio. If it is less than 300, it is ARDS. 200 to 300 is mild ARDS, 100 to 200 is moderate, and less than 100 is severe. In patients who have severe ARDS, mechanical ventilation is the ventilation of choice. So modes of mechanical ventilation. We have control modes, which can be volume control and pressure control and PRVC. Then we have synchronized intermittent mandatory ventilation or SIMV mode, in which the machine provides some breath and the patient takes some of his own breath. And then there are weaning off modes where the patient has to do most of the work, and these are like the CPAP mode, which can be volume controlled and pressure controlled. So what should be our ventilation strategy in COVID patients of ARDS? So this was a groundbreaking trial that we had. It was the ARDS NET trial, and on that basis only we are ventilating a COVID-19 patients. The trial says that first step is to calculate the predicted body weight of the patient. So for males the formula is 50 plus 2.3, and in brackets we need to have the height of the patient in inches and we need to minus 60 for that. So if a patient is 100 kgs of weight, we will not calculate it for 100 kgs, we will calculate it for the predicted body weight. And for females, the predicted body weight has to be calculated by 45.5 kgs plus 2.3 into height in inches minus 60. Then we have to select the ventilator mode. It is not specific which mode we need to select, it is which the doctor is comfortable with, he has been using. It can be either volume control or pressure control. Then we have to set the ventilatory settings. So our settings have to be set that we have calculated the predicted body weight. The first and foremost is the tidal volume. The tidal volume should be 8 ml per kg of the predicted body weight. Then we can reduce this tidal volume by 1 ml per kg at intervals of 2 hours until we have achieved the tidal volume of 6 ml per kg of predicted body weight. We have to set the initial respiratory rate, and this rate should not be more than 35. Then we need to adjust the tidal volume and respiratory rate to achieve the pH and plateau pressure. Plateau pressure on a machine should be less than 30. And SpAO2, that is oxygenation goal, is 88 to 95%. There are two strategies, low PEEP and high PEEP. So we have, if you are using a low PEEP strategy, it says that at an FiO2 of 0.3 you use 5 PEEP, and you can go up and increase it up to 18 to 24. The higher PEEP strategy uses a lower FiO2 and a higher PEEP, and here also they go up to 24. So next is, what do the Indian guidelines say? They say that in endotracheal intubation, those who are obese or pregnant, they may desaturate quickly. So first you pre-oxygenate them with 100% FiO2 for 5 minutes and then perform a rapid sequence intubation by a trained person. We already discussed the strategies how to keep a rate. Another important point that I need to stress on is prone positioning in ARDS. So this has been highly recommended for COVID-19. We need to start proning our patients, and the proning has to be for 16 to 18 hours a day. The contraindications for proning is spinal instability and intracranial pressure that may increase on turning. So this is how you prone your patient. And of course, we need to remember the 5 elements of a VAP bundle, that we need to have a head end elevated of the patient. We need to take care of the oral care. We need to give stress ulcer prophylaxis and daily sedation assessment and spontaneous breathing trial. And of course, the most important part is the DVT prophylaxis, or you can give it in treatment dose also. Thank you. Handing over to Puneet sir now.